Greetings, my name is Melissa Cunningham. I'm the program manager for the CDMRP's Prostate Cancer Research Program. I know all of you are here because of your shared passion to end prostate cancer. And so you want to hear what the PCRP is doing to help support that goal and what we've accomplished to help the prostate cancer patient community. But we aren't a standalone organization. We are just one of the congressionally directed medical research programs, all of which leverage the unique processes developed by CDMRP to accomplish, identify, and fund impactful research for patients. And so I'd like to start today by briefly introducing this congressionally directed medical research programs, or CDMRP, to help you understand the context under which the PCRP operates. As an organization, CDMRP strives to meet our vision to transform healthcare through innovative and impactful research. You'll notice in that statement that we aren't just trying to aim to advance basic scientific knowledge, but we are working to transform healthcare through innovative and impactful research, which makes us different from other funding agencies. So how do we plan to do this? By responsibly managing collaborative research that discovers, develops, and delivers healthcare solutions for service members, veterans, and the American public. Yes, we are part of the DoD, and so the impact we have on current and former service members is important to us. But we also want to ensure that the solutions we provide will also benefit the American public, since cancer and the other diseases that we fund research to address also affect general civilians. The success of CDMRP is based on a unique partnership among Congress, the DoD, researchers, and consumers. And this all started back in 1992 with a grassroots advocacy effort, which heightened political awareness and increased interest in particular health issues, leading to Congress to act by appropriating funds to support innovative and impactful breast cancer research. That created what would become the very first CDMRP program and drive our unique focus on funding innovative and impactful biomedical research. In establishing that first program, CDMRP grew and established these partnerships between Congress, the DoD, researchers, and the consumers, each of which plays an important and distinctive role, from the initiation of funds and the guidance of how to use those funds, to the program management and oversight, to the development of innovative ideas and products, and to the passion and perspectives of the consumers, all of whom work together toward the goal of transforming healthcare through innovative and impactful research. So what makes CDMRP programs different from other funders? Well, the first aspect is the fact that all research funds are specifically targeted by Congress and added to the DoD budget on a yearly basis. We are not part of the presidential core budget, and these funds are not taken from other parts of the DoD that support military operations, but are added to the DoD budget each and every year. The CDMRP specifically targets research according to each program area and funds high impact, high risk, and high gain projects that many other funding agencies may not venture to fund. The funds given to each program are specifically directed by Congress, often with specific language guiding the use of those funds. And so that means that funds dedicated to support, for example, prostate cancer research through the PCRP cannot be moved to another program or used to fund research in another disease area. Again, we're very cognizant of the fact that we are not the only funding agency that supports research in these areas. We do work very hard and coordinate with other federal funding agencies and private funding agencies to really try and avoid any duplication of research funding and ensure that we're doing our best to perhaps target underfunded or unmet gaps that others may not be currently investing in. The CDMRP follows the two-tier review application process that was recommended by the National Academy of Medicine. And that allows us to incorporate the traditional merits of peer review, which looks at the scientific merit of each application, as well as a programmatic review level, which really helps us target those important gaps within the portfolio of the program, or things that are of specific relevance to the patients that we're trying to support. And I'll describe this process in a bit more detail shortly. Another unique hallmark of the all CDMRP programs is the participation of consumers in our processes. Consumers, who are defined as individuals living with a disease, injury, or condition, or in some cases, their caretakers. These individuals participate throughout the yearly program cycle and really serve as the true north of our programs. Their involvement helps ensure that we are considering how these research efforts are going to ultimately support and impact the consumers that are not only participating in our processes, but are going to be the recipients of the results of our funded research. Again, this is another unique aspect that I'll emphasize again shortly. Each program's vision is adapted yearly, and award mechanisms are changed as needed to meet the current needs of the research community. And our review and funding process does not rely on a pay line approach, meaning that applications that receive the highest scientific scores are not automatically funded. Applications are recommended for funding based on both their scientific merit and how well they address programmatic criteria. Last point that I'd like to emphasize on this particular slide is the fact that CDMRP strives to keep our management costs as low as possible, which helps us direct as much of the funds that were appropriated by Congress towards those research projects as possible. These hallmarks were established with the creation of the Breast Cancer Research Program, and because of our successful approach to funding innovative and impactful research, Congress has continued to entrust additional programs and funds to CDMRP to manage. Today, CDMRP is comprised of 35 different dedicated research programs, as you can see on this slide. Congress just recently signed the bill, including FY23 appropriations for CDMRP programs back in December, which are reflected, the dollar values of which are reflected here. And our programs are just starting to plan for that fiscal year 23 process and are working hard to ensure that we strategically invest the $1.5 billion that have been entrusted to us to meet the congressional intent for each of our programs. Each one of the CDMRP programs follows the same program cycle, again, which was initially established when the Breast Cancer Research Program was created in 1992. And I wanted to spend a few minutes describing this in a bit more detail so you can understand how this process feeds into all the work that our program does. We start with a reminder that everything we do starts off with receiving congressional appropriations. Without funds being designated to the PCRP, we can't start the process of identifying new research to address our goals. But once the appropriations bill is signed, we start each year by reviewing last year's strategy and discussing any new gaps in research and patient care to determine the best strategy for those newly appropriated funds. To help us with those decisions, we work with a group of subject matter experts who make up our programmatic panel. They are a group of scientists, clinicians, representatives from other funding agencies, and consumers who all have an expert knowledge or perspective to provide in terms of prostate cancer research and patient care. Once we've determined the best strategy to address our goals based on the funds available, we then communicate that information by releasing different funding opportunity announcements or program announcements, which the researchers are then able to respond to by submitting applications for their ideas of how they can best address those goals within those funding opportunities. The submitted applications then go through our two-tier review process, which starts with a scientific peer review. At this stage, we again have consumers, scientists, and clinicians who are recruited to serve on review panels and review the submitted applications to help the program identify which ones seem to be most meritorious based on a number of predetermined review criteria. The program then uses the evaluations and scores to bring the strongest applications to the second tier of review, the programmatic review stage. Here, the programmatic panel, who helped set the stage at the beginning of the year at that vision setting meeting and recommended the strategic goals that we were soliciting applications for, they now review the strongest pool of peer-reviewed applications to ultimately help the PCRP determine and make recommendations as to which of those applications will best help us address the goals that the program has and will help us make progress towards the goals and ultimately get those important advancements to patients that we feel are really critical. After we decide which applications are recommended for funding, the program staff then works closely with the researchers to help ensure the success of the projects and identify the research outcomes that we share with you and other stakeholders to demonstrate the impact of our investments. Consumer involvement, which is a CDMRP hallmark from the very beginning, is an integral part of our processes. And as I mentioned before, really serves as what we feel the true north and foundation of CDMRP. Consumers serve as full voting members on nearly all CDMRP peer and programmatic review panels, which we just talked about in the last slide. And so they are involved in helping to establish the goals and strategy that the program uses. They help with evaluating the merit of the applications submitted and helping to determine which of those applications are recommended for funding. And this is important because consumer participation adds a unique perspective and a sense of urgency, ensuring that the human dimensions of prostate cancer are incorporated into our strategy and research focus. We are proud of the fact that we as CDMRP have involved thousands of consumers in our review processes over the years. Just last year alone, over 900 consumers representing over 400 consumer advocacy organizations have served on our panels. And I'm hoping that I've already caught the attention of some of you that are attending the summit today who are hopefully wondering how you can become involved as a consumer representative for the PCRP, or even perhaps for other CDMRP programs, depending on your life experiences. Consumers are invited to participate on peer review panels based on the involvement in their advocacy organizations, outreach or support organizations, perhaps involvement with armed forces, and their personal experience with the disease or condition. And of course, the first easy step that I believe Ali has already mentioned to you today is to start talking with her and others that are in attendance at the ZERO Summit that have served for the PCRP before about their experiences and the process that's involved in getting nominated and starting that initial discussion with our consumer reviewer administrator. Our consumer reviewer administrator, who works directly with the consumers for this purpose, her name is Melissa Flathman. She unfortunately could not be at the summit today, but she does have a virtual ZERO booth that you can visit, and I believe also has a Zoom link where you can reach out to her directly and engage in conversation to ask questions if you're considering getting involved. This is a great time to start that process and prepare you to be involved in our fall review meetings, so I hope you will give that some consideration. So now I'd like to start by diving a bit more into specifics about the Prostate Cancer Research Program, or PCRP. And as I had noted, our program uses our vision setting meeting to plan for each fiscal year with the involvement of our programmatic panel members. To accomplish this annual planning, we really incorporate and consider a number of important aspects when ultimately trying to determine what the goals of the program will be. We always ensure that any strategy we establish is in line with congressional appropriations and any specific language associated with those funds. But we also consider input and guidance from senior leaders and stakeholders. We assess the current research landscape and what other funding agencies are currently doing to address prostate cancer research, ultimately helping us to determine how to best leverage the funds that we've received from Congress to address the most critical gaps and unmet needs. Ultimately, all of these aspects help us determine where the program feels that we can make the greatest impact, considering also our prior investments and the current research funding landscape. The vision setting process helps us reaffirm the program's vision and mission, the ultimate goal of what we are hoping to impact through the research that we are funding. And for many years now, the vision of the PCRP has been simple and straightforward: to conquer prostate cancer. And therefore, our mission is to fund research that will lead to the elimination of death and suffering from prostate cancer and enhance the well-being of service members, veterans, and all the men and their families who are experiencing the impact of the disease. Our mission statement reflects the fact that we are aware that all men are at risk of developing prostate cancer, but we also want to ensure that we're supporting the health and well-being of our service members and veterans as part of the Department of Defense. I realize this audience is well informed about the incidence rates and risk factors associated with prostate cancer in the service member and veteran populations due to the ZERO Veteran Collaboration Group, but I wanted to make sure to take a moment here to just highlight the impact that prostate cancer has on our military health system. CDMRP worked with the Defense Health Agency's Health Surveillance Division to obtain information on the burden of prostate cancer in the military health system, or MHS. And as you can see here, this disease places a tremendous burden on the MHS, with over 210,000 patients seen for care due to their prostate cancer between the years of 2010 and 2019, which has resulted in also in more than 3.5 million patient encounters or visits to the MHS treatment facility. The majority of these patients were not active duty service members at the time that they were seen, but in the group of what we call other beneficiaries, which includes veterans. And in fact, of those patients in that other beneficiary category, 95% were former service members. So of course, this is something that the program keeps in mind when we are developing our strategy to ensure that we are supporting research to reduce this burden. The amount of appropriations given to the program also plays a big part in our strategy. We're fortunate to have received funds to support the PCRP every year since its inception in 1997. And we continue to be at the highest funding level in the program's history at $110 million for FY23. Thanks, of course, to ZERO and others who have voiced support for the program over the years. The number of awards that we have been able to make with the over $2.26 billion in total appropriations to date is more than 3,676 awards or projects, all focused on prostate cancer research. To help us focus our efforts and make the biggest impact possible, the program has released our inaugural strategic plan back in 2018 that identified specific areas that the program decided to focus on addressing. This is not to say that there are not other important issues within the prostate cancer research and patient landscape that shouldn't be addressed, but simply that these are the areas that the program feels that we can make the biggest impact on with the knowledge of our program's unique strengths and what other funding agencies are also currently supporting. You can view the strategic plan on our website, but I will note that we will be updating it this year to reflect the latest accomplishments from the program and the current language for our strategic goals. And you could expect to see that sometime during this calendar year. Since the development of that strategic plan in 2018, we've been prioritizing 4 areas that we are challenging the research community to address through their research proposals. While the phrasing of these challenges, which we call overarching challenges, has been tweaked a little bit over the years, the core focus remains the same, which is to better understand the biology and identify new treatments to improve outcomes for men with lethal prostate cancer, who are in urgent need of new options. We have also been committed to supporting research that will help improve quality of life and enhance outcomes for patients who have been negatively impacted by their prostate cancer diagnosis or treatment. And lastly, we continue to be committed to addressing prostate cancer health disparities for all patients that might be disproportionately affected, including different races, ethnic groups, current and former service members, and others. To help us address these goals, we continue to offer funding mechanisms that help support both highly innovative ideas that may produce the next landmark discovery or breakthrough, as well as studies that prioritize translating promising ideas closer to making a more immediate impact on patients. And you'll note here in the pie chart, which represents our investment strategy or the planned investment for FY22, which was last fiscal year, that we do have a larger portion now dedicated to innovation than we have in years past. And this is in part due to the fact that with the impact of the COVID pandemic, many researchers' translational pipelines have been affected. And so we felt that it was important to put a little bit more of the investment towards supporting the innovative new ideas that may continue to fuel the pipeline in the future. I also want to point out that the 8% that you see that's classified as supporting resources is actually used to fund the infrastructure for our clinical trials consortium. And I'll come back to that particular investment and its accomplishments in a few minutes. So how are we doing in addressing these goals? Well, PCRP funding has supported many different studies over the years that are continuing to prime the pipeline with new discoveries and promising diagnostic and therapeutic interventions. Some of those early discoveries have become widely available and changed the standard of care for prostate cancer patients, including biomarker assays that detect aggressive variants of prostate cancer, new imaging agents, and multiple treatments for patients with advanced prostate cancer that are now even being further expanded with the FDA approvals to more early disease stages. Our program is also proud to have contributed to these advancements and the impact that they have made for many patients, but we recognize that newer, better treatments are still needed. So I'll touch on a few more advancements from this slide in detail in the next couple slides. So one great example that I wanted to emphasize today of the impact that our effort to fund innovative ideas can have started off with an investment that we made many years ago in an idea from Dr. Martin Pomper at Johns Hopkins University. Dr. Pomper took his experience in neuroscience to come up with a brand new idea about how to develop a small molecule agent that could be used for more sensitive functional imaging of prostate cancer using the PSMA or prostate-specific membrane antigen molecule that is expressed on the surface of prostate cancer cells. The result of his PCRP-funded work was the development of the first practical human PSMA-PET agent that uses the 18F radio label as a imaging label. This agent showed a lot of potential, but was ultimately surpassed by other more promising versions of the PSMA-PET agents that were developed after Dr. Pomper released his findings. And as many of you have heard, probably to date, the first PSMA-PET imaging agent finally received FDA approval in November of 2020 called PYLARIFY. And while that particular agent that Dr. Pomper developed with the PCRP funding was not the exact ultimate agent that received FDA approval, which is very typical for most therapeutic development pipelines, his innovative approach that the PCRP funded to design a brand new innovative imaging agent laid the foundation for the development of many other PSMA-targeted imaging agents and ultimately enabled the work that was FDA approved. Another project I wanted to highlight that has led to patient impact was work done by Dr. Wasim Abida from Memorial Sloan Kettering Cancer Center. Dr. Abida had received a Physician Research Award from the PCRP, which is a funding opportunity specifically designed to bring clinicians into the research so that they can apply their unique clinical perspective through patient interaction into addressing critical research questions that would be in line with patient needs. Dr. Abida had proposed to use patient samples to identify or study the different types of prostate cancer at a molecular level, looking at changes to the genome, as it had been observed before that changes to the genome can cause the cells to start behaving abnormally and contribute to prostate cancer progression. And he was focused specifically on a set of genes called DNA repair genes, which can be altered in up to 25% of prostate cancers. Through his work, he had identified a subset of prostate cancer that had deficiencies in these DNA repair genes and displayed a specific feature called microsatellite instability. Previous studies had demonstrated a link between tumors with microsatellite instability, or MSI, and responses to a newer class of drugs that were called immune checkpoint inhibitors. From this information, Dr. Abida further investigated these tumors and even noticed a specific link between the mutations in the specific DNA repair genes BRCA1 and BRCA2, and which those patients who had a favorable response to PARP inhibitors. So these important findings enabled Dr. Abida to then work with a team of clinicians that were developing the protocol for a new clinical trial that was going to be testing the efficacy of a PARP inhibitor called rucaparib for metastatic prostate cancer patients. Dr. Abida used these findings from his DoD project to help shape the design of the clinical trial to target the investigative agent to the patients who are most likely to respond. And the favorable results led to the FDA approval of rucaparib back in May of 2020, one of 2 PARP inhibitors that were FDA approved that year for men with metastatic prostate cancer. So in supporting this study and Dr. Pomper's study, the program knew that it was potentially taking a risk, supporting ideas that thankfully did eventually make a big impact on patient care. But we want to balance those high risk and perhaps innovative ideas with studies that we know can help ensure to continue filling the pipeline with new potential treatments for patients. And the approach the program has been using for over 15 years now is the support of a collaborative group of clinical research centers that we bring together with PCRP support, creating what we've called the PCCTC, or Prostate Cancer Clinical Trials Consortium. The idea behind this investment was simple: to rapidly advance clinical testing of promising therapeutics by engaging multiple clinical sites in the trial design and patient recruitment. And this has been arguably our most successful investment, resulting in the enrollment of more than 13,900 patients accrued to more than 258 clinical trials, all focused on prostate cancer since 2005. And the results of those studies have moved 20 agents to phase 3 testing, including most recently breakthrough designation of niraparib, and ultimately the FDA approval of some of the most notable new treatments in prostate cancer over the past 10 years, including abiraterone, enzalutamide, apalutamide, cabazitaxel, rucaparib, radium-223, and olaparib. And in line with the program's focus on addressing health disparities, the consortium sites are also required to recruit patients from groups that are disproportionately affected by prostate cancer, including different racial and ethnic minority groups and those from the veteran population, to ensure that we are having a broader representation of patients who might have different outcomes from the trials that are being conducted. And while these achievements are tremendous in meeting the original intent of this investment, the amazing fact is that the collaboration supported by the PCRP has gone beyond these initial requirements, creating an even further impact on how prostate cancer clinical trials are being conducted and ultimately on the clinical care of patients. And I realize I'm probably running a little short on time, but I want to quickly highlight some of those additional achievements and efforts here. This particular collaborative group has leveraged their knowledge at 3 different points in history to develop consensus guidelines for how to conduct trials in prostate cancer, with the most recent being the release of guidelines specific for conducting metastatic castration-resistant prostate cancer trials. And the group is currently working on another iteration of this with the impact that imaging agents, such as that PSMA-PET agent that I talked about, how those imaging agents are impacting the clinical management of prostate cancer and thus how they should be incorporated into the design of clinical trials. That effort's underway and will be coming out in the near future. The group has also recognized the impact that new genetic tests have had on informed decision-making for patients. And so again, the Prostate Cancer Clinical Trials Consortium came together to provide guidelines for clinicians on how to best incorporate these powerful tools when helping to guide patients in making an informed treatment decision based on the results. I also wanted to highlight 2 particular patient registries that the group has been really instrumental in standing up and executing. These are initiatives that are looking to gather large amounts of information from patients to help better understand a specific group of patients or their disease, and ultimately helping us to understand how to revise approaches that might help address the needs of those patients more specifically. I believe both of them, these are the Ironman and Promise registries, are still actively recruiting patients. So if you're interested, I'm sure you can find more information on clinicaltrials.gov, or please reach out to Allie and she can be in touch with me and I can send you information if you're interested in participating. The Ironman registry is a prospective international population-based registry aimed at optimizing overall survival and patient-reported outcome measures for patients with advanced prostate cancer. And the PROMISE registry is the prostate cancer registry of outcomes and germline mutations for improved survival and treatment effectiveness. The last thing that I really just wanted to quickly point out, which is the newest effort by the PCCTC, which is still under development, is the move towards an adaptive platform trial design. It's a little difficult actually for me to explain, and I'm still learning along the way exactly how this works. But essentially, my understanding is that the benefit of this non-traditional approach to clinical trials, which has been tested in other diseases, allows the consortium to quickly and easily add in new treatment arms or approaches into an existing scaffold or trial platform without compromising the validity and integrity of ongoing trials. And essentially what this does is it helps make clinical trials more flexible and efficient, getting results and new treatments to patients even faster than this group has already been able to achieve, especially for those patients where perhaps one single treatment option is not enough. So I'd like to shift now to another priority area for the program, specifically focusing on health disparities. The PCRP has been supporting research in this area since the beginning of the program, and we have been emphasizing the need to support research to help us understand and address all aspects that might be contributing to health disparities in high-risk or underserved prostate cancer patients. This includes patients that might be considered high risk for biological reasons, perhaps such as inherited genetic factors or exposure to cancer-causing agents. Perhaps they are at higher risk because of social or economic reasons, including financial status and access to care, or any other number of different factors. Since 1997, the PCRP has invested over $200 million to support 290 projects aimed at tackling this issue of health disparities. And I wanted to briefly highlight a few examples of our efforts in this area. As we mentioned earlier, there's oftentimes a lack of diversity in clinical trials. What's demonstrated to work for one group of patients is then generalized for a larger group of patients. And one example of this is, for example, the use of PSA testing, which might be informing also active surveillance for patients whose tumors might be perceived as perhaps being very slow growing and may wish to defer unnecessary treatment. For African American men who have a higher incidence and mortality rate and are often underrepresented in clinical trials, it would be unclear to a provider and the patient if something like active surveillance might be a viable option. So Dr. Brent Rose, a clinician affiliated with the Veteran Health Administration through the University of California, San Diego, proposed to use the VA's health system to see if Black men had similar outcomes to white men if they had elected to go on active surveillance and defer treatment until it was deemed necessary. The benefit of using the VA health system is that it's believed to be a bit more of an equal access to care system, eliminating the variables that insurance and socioeconomic status might introduce into these types of studies. It also provides a very rich and detailed set of patient data for all the patients that are in the system. What Dr. Rose found was that, interestingly, Black men were not more likely to experience cancer spread to bones or other metastatic sites or to die from their cancers compared to white men, but that overall the differences in outcomes between racial groups that were seen in other studies essentially appeared to be substantially diminished or eliminated within the equal access to care environment of the Veterans Health Administration. This is important information for us and other researchers and clinicians to help us understand the possible factors that could be driving disparities in disease outcomes. Additionally, Dr. Rose's team found that Black men were more likely to experience disease progression at lower PSA velocity thresholds compared to white men. PSA velocity is the measure of how quickly PSA levels are changing over time, with higher rates or velocities associated with more quickly advancing disease. So by identifying the fact that prostate cancer in Black men progressed at lower PSA velocities compared to white men, this provided valuable insights into how Black men can be safely monitored on active surveillance using criteria that might reflect differences in the disease between the two racial groups. These results have now been incorporated into the National Comprehensive Cancer Network guidelines, which are the most widely utilized oncology guidelines in the United States and can be directly discussed between physicians and patients to support informed patient decision-making and potentially help men feel more confident in their choice to perhaps delay aggressive treatment and avoid unnecessary treatment side effects. The last study I wanted to share with you today is related to the quality of health information from online sources and its potential impact on health disparities. If I was with you in person today, I would ask all of you to raise your hands to see how many in the audience have used the internet to look up medical information. And I'm sure there would be more hands in the air than not, including my own. The internet is a powerful tool, but can also be problematic if the information that we are receiving is not from a trusted source. Dr. Stacy Loeb from the New York University's Langone Medical Center had already performed studies previously demonstrating that many websites and YouTube videos about prostate cancer are biased or misinformative, and that patients who get their information primarily from online sources are more likely to regret their decisions about treatment compared to those who primarily receive information from a physician. Relative to the issue of health disparities, data shows also that Black adults are more likely to use and trust online health information sources than white adults. And so Dr. Loeb wanted to investigate whether exposure to biased online content is contributing to prostate cancer health disparities in the Black population and in Latinx men, both groups of which have demonstrated a distrust in the healthcare system and increased reliance on other sources for healthcare information in their decision-making. Dr. Loeb's results so far have shown that the prostate cancer websites and videos that they reviewed generally lacked Black and Latinx representation, and that the content that did include Black or Latinx representation was not of high quality, understandable, actionable, or at the recommended reading level. For some of you, this result may not seem surprising. Perhaps you already have a distrust of online information. But having these findings documented can spur the creators of these resources to be more inclusive in these visual and audio materials, so that many patients are seeking and using to guide their personal treatment decisions. And the goal is that any efforts to increase the quality and diversity of information being provided may help mitigate disparities. Dr. Loeb's project is continuing investigation right now along these lines to also see if there's any relationship between how patients respond to information that they have available, depending on who is providing that information in online materials, and to see how these resources can be modified to enhance their utility for the audience that they are intended for. So I hope that you were all able to take away from this presentation today something new about the advancements that our program has supported, or about the ongoing studies that we hope will be able to impact patients in the not too distant future. But of course, this is only a sampling of the different research efforts and accomplishments that the PCRP has supported. We regularly communicate new research developments on our website, and you can see a sampling of those web highlights here. In addition, and in keeping with the patient-centric focus of our program, we also like to share the personal stories of men who are dedicated to helping shape the program's efforts by participating in our review processes. So I hope you'll take a few moments to go to our website and check out some of the recent highlights that we have posted in those consumer stories. Again, you can keep up to date with these news releases and research highlights by going to the CDMRP website, and the address is listed here. You can also subscribe to our program communications, or also follow us on Twitter or Facebook. And again, I hope I've inspired some of you to consider participating as a consumer reviewer. And again, please visit the virtual booth or reach out to Ali or other members at the summit today to find out how to start that process. So again, thank you to ZERO for inviting me to share this information with you, and for all that the ZERO community does to support prostate cancer patients and for helping to fight this important battle against prostate cancer.